Good afternoon, everyone. iTech India welcomes all the participants for today's special National Distance Learning Seminar session. Today's topic is Step Up Adherence Counseling, and the speaker is Dr. Ramesh Allam. Dr. Ramesh Allam, sir, is working as the Public Health Specialist with CDC India. We welcome you, sir, for today's session and request you to start the session.
Yeah, good afternoon all, and welcome for this session on Step Up Adherence Counseling. So today we will start on the session objectives are mainly, just a second, there's some problem.
So click on the slide and then go to the next button. Yes, it's visible, sir.
Yeah, sorry for that. Yeah, so the objectives of today's session mainly will be to monitor our patients who are on ART. And one key important step of monitoring is counseling. And how do we differentiate between a normal session of counseling and where do we strategically put these patients during our routine clinical visits, and how do you do adherence monitoring and also management of patients with unsuppressed viral load? How do we do that, and what is the concept of U is equal to U? So these will be the key focus areas, and next we will go to the pre-test questions, and mainly we have three questions.
Kiran, sir, can we have the pre-test, please?
Okay.
Yeah, the pre-test questions are now visible on your screen. All the participants are requested to please attempt all the three questions. So we have 3 minutes for the pre-test.
Yeah, the first question is the success of antiretroviral therapy depends on. You need to select one best choice, that is adherence to ART or the type of regimen the patient is, or it's proportional to the age of the patient, or all the above. So that's.
Participants are requested to please select the answer on the screen. The second question is PLHIV is initiated on ART and at the end of the 6th month, he missed a few doses of ART. Which of the following is the best scenario to manage this patient? The options given are counsel the patient and refer for viral load test, delay the viral load test until the patient PLHIV attains the desired adherence, counsel the patient, refer for viral load test, and utilize the viral load test result for further motivation. PLHIV initiated on ART in 2020 is now due for annual viral load test. The counselor and medical officer referred the PLHIV for viral load test, and the viral load result was 20,000 copies. ART staff initiated EAC, and in the 3rd month, the adherence was not adequate, that is less than 95%. What is the best option for this patient? The first option is counsel the patient and refer for viral load test, continue EAC for additional 3 months, and then refer for viral load test and refer to SASL.
Ma'am, someone is ending the poll. We'll relaunch that.
Sure. For those who have not attempted the poll, please continue. Kiran sir, we can end the poll.
Okay.
So please continue.
Yeah. So the first objective of today's session is mainly to look at what are the monitoring tools available with us while we actually provide care to our patients. So as you know, the initial evaluation that we do is mostly of virological, immunological, and clinical. And we also evaluate the new clients for adherence as one key mechanism. And also, we also need to monitor the patient for adverse drug reactions, whether the patient has any opportunistic infection and an immune reconstitution inflammatory syndrome. So, one of the key important thing that we all tend to forget is adherence is part of the treatment package itself. So you cannot separate counseling and the clinical management separately. So always, whenever we talk of a HIV positive patient coming for our clinical visits or to an ART center during every footfall, we start with 4 symptom screening, counseling, and then we go to the dispensation or oversight by the medical officer. But we do not just still pick the drugs and go. And there is also, you would have heard during the recent trainings and presentations about the patient-centric package of care and how do we deliver that package of care within the ambit of our routine services that we offer to the patients. So one important thing that we should be doing always are to assess first the patient whether he is responding to treatment. That we do through viral load count. We ask certain questions clinically if the patient is doing good, or we also see if there are any adverse events. And if you see the last point on adherence monitoring will start even before you start the antiretroviral therapy. So the initiation of antiretroviral therapy is preceded by a preparedness counseling. If you see the operational guidelines, there is a 7 point a checklist that you have while we prepare the patient for antiretroviral therapy. And we need to keep that pace because every patient who is initiated may not know everything during the first visit, second visit, third visit. So it is a continuous process that we need to keep emphasizing to the patient. And if you see every visit of the patient, we need to look for pills if the patient is bringing the pills, or we need to do a viral load monitoring at 6 months and then annually, 12 months and then annually. So these are the tools that we have, and adherence is one key important tool that we have with us while we do with the routine patient follow-up. Now, if you see adherence, why is it important is, as you have seen in the first question, what we have told is the success of the antiretroviral therapy is independently associated, or it is significantly associated with adherence. So if you do not have adherence, but I am on the best regimen available in the world, definitely your viral load count is going to be higher. So there is directly proportional relation that you see as your adherence increases, your success of antiretroviral therapy also increases. And for the outcome of the treatment that we see is that the patient should have a suppressed viral load. So based on our national guidelines, we say suppressed viral load is less than 1,000. So if viral load count is a very important tool for us to monitor the treatment outcome of the patient. So there are two things that you can assess when you have a viral load count. Number one is whether the patient is having a low or a high viral load. So in patients with a high viral load, that means either the patient is really treatment failing or the patient is not taking drugs. That's how the viral load is higher. So there are two things that we can actually make out the help of a viral load. Number one is whether the patient is actually taking the pills and that's why his viral load is suppressed, or I'm taking the pills intermittently. And what we say is before you refer for a viral load test, you ensure that the at least the adherence the patient is reporting is more than 95%. In our program settings, we do not have an objective assessment of the adherence. We do not have urine tenofovir measures or taking the hair samples and looking, or nail samples and seeing. We just depend on the pill count, or we ask the patient, or if he is coming after due date, we ask the patient. If somebody is coming on a due date and not bringing a pill box, this is very important scenario wherein 50% of our patients come with this scenario is, I'm coming on the same day, I do not have a pill box. So as healthcare providers, we need to ask 2 to 3 very simple questions to understand the adherence of this patient. Very simply, we ask, in the last 2 to 3 days, when did you miss any pills? So that is how we need to question the patient. Don't ask like, in the last month, did you miss any pill? I mean, obviously the patient is going to say no. And nobody can remember in the last 30 days when did I miss. So it's always very good practice as you ask your patients, put some time, like in the last 3 days or in the last 1 month, did you miss? And if somebody says yes, don't shout, don't yell, but you just ask what are their challenges and why they could not take those drugs. Now we also have in this slide, you can see the checklist for treatment adherence. A checklist is like, is the patient coming on time for a pill pickup? Is he always coming after the due date? If that is a question, then you need to have 2 options. So all of you, can you put in your chat box, why do you think the patients are coming after the due date? It is all your experience, but I want to see the chat box. Everybody just write a reason why patients are coming after the due date is given to them. Any reasons that you know? I'll give you all 1 minute. Why do patients come after the due date? Common reasons, because almost 130 people are attending this call. I want to understand from you all, in your centers, in your experience, what do you think is the most common cause why patients are coming after the due date? I can't see anything in the chat. Nobody's doing. Oh yeah. Good. PCOE. Cyan has put up family issues, functions, non-availability of funds to travel. Sapna is saying function at home, behaviorist issues, out of station, lack of money, work leave, remaining medicines, work leave not allowed, occupational purpose, religious. Okay, good. So these are all the reasons that you are telling based on your experience from each of your centers. If you look at these reasons, there are certain reasons that are modifiable. That means they are occurring just on this visit. And there are some reasons that you can see which will perpetuate to next visits also. For example, financial reasons that may happen not just for 1 visit, but 2 visits, 3 visits. There are certain reasons which may have just for this visit, like I had a function. So you need to differentiate between those barriers the patient is facing, which could be a long-term ones, which are a short-term, and which are a one-time. So most of the narration that I have seen are mostly a one-time, and everything has a solution. For example, if somebody is not having money to travel to the ART center, he will be one of your best case scenario for a 1 month, 2 months, or a 3 month dispensation if drugs are available. And if somebody is having an occupational issue, possibly he's the patient who should be actually given the drug in the first hour in the morning or in the last hour in the morning. So something like that, these are the solutions that we need to offer as part of the adherence. We should not just listen to the barriers that the patient says, but we should be offering certain solutions. And yeah, don't remember is another very important one. And for that, I know most of you as healthcare providers do tell them to put up some alarm or try to relate it to a temple bell or relate it to some TV program. I think these are all some of the tips that we offer to the patients, and thank you all for your good engagement. And we also will count on number of doses that the patient. And very important reason some of you have already put up is actually patients have surplus drugs already with them. So when you're calculating the due date, that means we have missed out asking the patient whether he has any other pills with him. Otherwise, what happens is every time he comes after the due date, and possibly this patient will be looked at a patient who is regularly a irregular patient. That sort of label we brand him just because we do not assess how many drugs are in his hand. If we don't assess that, we usually normally say 28-day drug pickup or 30-day drug pickup is what we write it in the green book or in the white card. So these are the things that we know. Most of you know it. Now we are more worried about looking at the solutions for this, why the adherences. And during the recent capsular training programs, I had an opportunity to take this session, and all are struggling actually to calculate adherence. So, and one of the participants told me, sir, there is an app, sir. We do it in an app, it will give you, but the numerator and the denominator that you need to feed in the app will not come from air. You need to know that. You need to know what should be the denominator and what is the numerator of it. So please, most of the counselors have almost forgotten, or I just don't say counselors, most of our ART staff have forgotten to calculate this one. So please see it and keep doing thing. And even when you're putting it in the app, just correct your formula and see whether you are feeding the same thing. So this is the only thing that we need to learn. Now, coming to viral load monitoring. So everybody knows that all patients who are initiated on ART should get their viral load in the first 6 months, then followed by 6 months, and then annually. So this is the routine viral load monitoring schedule that we have within the program. And if everybody is able to see the screen clearly, what we are saying is the patient is getting a viral load count initially at 6 months, or it is his first viral load if the viral load is the first viral load count. We do not have anything specifying adherence between the triangular box and the viral load count. Between that, we do not have anything in the first 6 months. So most of the medical officers or most of the staff tend to ask this question during the first 6 months when we are referring the patient. Should we look at the adherence? It's good always to look at the adherence, but you need to remember that that is the patient's first viral load that he or she is going to get. So you continue to counsel the patient, tell that adherence is a determinant of the success for ART. It reduces the viral load. And once you get the viral load back and you're confident that the patient is not adherent and you're getting a high viral load, this is going to, you can use this as a motivation factor for the patient. Tell the patient that, see, I already told you you're not adherent. You see your viral load is so high. Now you need to reduce this from this number to this number, and this happens only in the next 3 months of your time. So this is how we can rationally use that first viral load or that 6 monthly viral load that the patient is going to get. Now, the second problem that we have is if the viral load is count is coming more than 1,000 or more than 1,000 in patients. So you see the algorithm, it says that you get a step-up counseling and to a patient for a minimum of 3 months. Okay. And I want you all to notice that word, a minimum of 3 months, because this is not a magic number. What we say is every patient is different, every behavior of the patient is different. So possibly 50% of your patients who are virally unsuppressed may take just 3 months to straighten their adherence, but maybe other 20% may require 4 months. Some of them may require only 2 months. So it depends on the patient how much time they take to actually um, have that adherence correction. So on an average, most of them will be having or they will revert to their best practice of adherence within 3 months. So that's how they're saying at least minimum of 3 months. So you will have some very minority of patients who may not be able to overcome the barriers to adherence. So in them you can have plus 1 or 2 months, but do not just hold the patient for this. So we will see in the next slides why not and all. Okay. But the bottom line from this slide is at least for the first viral load, if you think that the patient's adherence is not good, you continue to counsel him on adherence and you use that viral load test as to motivate the patient to bring his viral load down to as low less than 1,000. So that is a scorecard for him that you are showing that, see, we know that you are not taking, and this is the proof that we have that you have not taken. So we need to now get your count less than 1,000. Now, this is another slide that most of you are aware. You would have seen the capsular training. We have used this slide too. So it's like a signal if you have an unsuppressed viral load. If you have an undetectable viral load, it is not detected. That means it is zero. There is minimal risk, and there is no transmission to the sexual partners. And if it is suppressed, but it is less than 1,000, okay, then we need to ensure and start counseling this patient from now itself. Not the real step up counseling, but they need to be targeted differently because it is not zero. There is some risk of transmission yet. And unsuppressed, you see that these people are most at risk of transmitting the infection and possibly they could be in a failure. So with these three strict things, so undetectable in our parallels, what we say is TND, that is target not detected. Now I will switch you back a bit to the patient-centric packages of care or the differentiated package of care. We know that every patient cannot be dealt in the same manner. So as you've seen in the operational guidelines, every patient who has undergone a viral load, that is after 6 months, they will be either going into a package B or a package C. Now tell me, a patient who is coming with a viral load count more than 1,000 to your center, which package should the patient be getting? Is it A, B, or C? You can use your chat box. Unsuppressed viral load, where do you put the patient on? Yes, so good. So you are putting the patient and hope wherever the training is done, you all are practicing this patient-centric package. So now you put the patient in package C. So what? Good. Thank you all. Yeah. So you can see from the slide that when a patient is in a package C, what is the first thing we are doing? That is a viral load testing. We are doing a enhanced adherence counseling and a e-referral we are doing. So that is the first and primary thing that we do. And we will not have many patients who have a viral load count more than 1,000 in our centers. You can see your own center data, and if 100 patients are there and if everybody has got their viral load test done, you will see around 8 to 9 patients per 100 patients at the maximum who have a viral load greater than 1,000. So these small or the minority of patients are your real patients whom you need to take care with utmost need. So that is the reason we need to segregate the patients into these package of care, and these patients will be going into package C. So what we will give is step-up counseling, repeat viral load after 3 months, and they should have an individualized approach. When can you have an individualized approach is only when you start looking at the patient specifically, prioritizing the patient as a real risk patient for infection transmission to the community and for drug resistance in himself. So if you see the operational guidelines, management of patient with unsuppressed viral load, if you see, immediately as soon as the report comes to you, And if you see that the patient's viral load is more than 1,000, a call should be going on the same day to the patient, because we do not want to waste any time. Because the patient has a high viral load, we don't know it's because of a real treatment failure, or it is just because the patient is not adherent to the treatment, hence the the viral load has swelled up. So you want to call the patient and call him back to the ART center. If the due date is somewhere between 10 days and all, the patient may not be able to come back. So you start the counseling telephonically. When I say counseling telephonically, we will be seeing what you should be offering, what you should be collecting during that first visit. And then a minimum of 3 sessions if required. If you want the patient a monthly session, you can also have a fortnight session or a 15-day session with the patient, depending on the condition and the barriers that the patient is actually facing. And this should be usually done by one counselor, and it should be notified to only that person. You need to tell that person, the patient whom we are counseling, that they need to come back to the same person, so that you will help them out in terms of providing solutions to overcome the barriers. And also during this step up counseling, what we also say is to for testing of the spouse or the partner. This is an important mechanism that we forget, because now the patient has a high viral load, and during this time we saw that the transmission is really high. So you also want to ensure that the patient has not transmitted the infection to the family member. So you also want to test the spouse or a partner if they were not tested or not documented prior to it. Now, if you see the step up adherence counseling, what we again say is to be done by the same counselor. And during patient visits for pill pickup, they can be conducted. Needs to review factors that lead to non-adherence. This is the first step what every healthcare provider in the ART should be doing. That is, you want to understand why or what are those barriers that the patient is facing, and why he's not able to take the drugs regular. This is the first step. So for this first step, I just go, yeah. So in the first step, what you need to understand is the patient is having a high viral load. So we need to target whether the patient has that enough knowledge to understand what is the meaning of a high viral load. So first target on the treatment literacy part of it. So if I am the patient, if I am having count more than 1,000, you as a healthcare provider should tell me and ask me, do I know the meaning of this result? That's the first thing. Once I know the meaning of the result, possibly then I realize that, okay, so this is why I need to take my drug. If you start thinking about, put yourself in the patient's shoes, and if you do not know the meaning of a high viral load, then why will I at all pay attention to taking drugs? So first thing is, I should be empowered, or I should be at least given the knowledge that about the result of the viral load. What is it? Once the patient understands, then you start slowly asking, okay, now you understood what it is. And this means that you may not be taking the drugs. So can you tell me the reasons why, or what are the challenges that you are facing to take these drugs? So this is how you need to have some open-ended questions, asking the patient to tell you and share with you how you can be of help to make him or her take the drugs regularly. So they may share with you some side effects, they may tell with you the timing of the drugs. You all told the same thing. And you should keep offering solutions for each of this the patient has asked. Now, once you have recorded a couple of barriers in my first visit, for example, if I would have told I am not remembering the pills, how to take, I told you as a counselor, and you have noted it as my barrier, and you would have given me an advice to put up an alarm or something. Now, if I am your same patient coming back to you, you already know that I came back to you. So you will open that checklist and see what you told. Suppose you would have told that you are taking, I told you to put up alarm Then you will ask the patient, hey, have you put the alarm in the phone? How is it working? Now, how many times you forgot in the last week? Is it much better? So this is how we need to start the conversation with the patient based on the previous solution that you are offered. If you do not have the previous record, or if you are another counselor, if he's coming another place, it is, you cannot have that continuity. So hopefully all of you now understand why we are saying that the same counselor, if you have, it is going to be beneficial for both the patient and the provider, because you already know the solution that you offered, and the patient will obviously tell you what is the improvement between between the first visit to the second visit. Otherwise, now if you're coming to another person, this is going to be the first visit for the provider, so that defeats the purpose of the counseling. And you may tell me, sir, we just we have a high patient load, all that. I'm telling you, these are the C category patients, and we should not have any reasons to not to be adherent to the guideline for these group of patients. A plus, A and C are the patients who best need your care. Okay. So the second important point is, if you do not have staff, there is a checklist that we have provided in the operational guidelines to use it during every visit. At least if there is a checklist, it is in the white card and you have written the solutions, you have offered what is a barrier, it may be helpful to continue for the second person. So if these two are not working, that means there is no EAC in that center at all. Take it from me that EAC is not happening. Either the patient is not going to the same counselor, number one, or at least there should be a checklist that we have in the guideline as part of your white card, because that is the only way how you can follow. Otherwise, it's going to become a routine counseling, and the patient is not actually getting a step up adherence counseling. The same thing. And in the third visit, if you have a 95% in the last 3 months, plan a repeat viral load. Okay. And if the viral load is good, you encourage the patient. If the viral load is higher, take another chance. Take another chance of 3 months, because what we are seeing from the data is some patients are taking more time. So at this point of time, what you should see is you tell the patient, you tell them the difference. What is the difference between their first viral load they got and the second viral load? If suppose the first one was 80,000 and the second one is 10,000, you tell them, it is encouraging that yes, the drug is working. You are working on your adherence. Let us extend it to other 3 months. So this is how we need to use that result. If the patient, you thought he was adherent and you have proposed and you have sent for a viral load test. Suppose you find that the patient is not adherent, even with the best solutions that you offer. But if you are seeing an improvement in his behavior, you can extend it, because what we have seen is extending is also helping in some of the patients, and the resuppression rates are higher among those patients too. So, and then maybe think of referring the patient to SASEP. So these are some of the things that you have to look into. Yes, it is a person-centric approach, so what we say in common may not apply, but at least you do it after 3 months. If you think the patient is not adherent, then you wait for another 3 months and get it done. Okay, and you will be getting some more guidance on this, how exactly to wait for how many months. You will get it from NACO. NACO is working out a mechanism to again give a standard communication on this. Okay, so this is a checklist what we have discussed until now: session 1, session 2, session 3. I'm just zooming that up. If you see in session 1, there are all the barriers that we all have spoken about. Okay, please, you need to check that, and you also have to tell him whether he needed some support. He needs to be, if there's no money, maybe you think of giving 2 months and you keep calling him, or let him keep calling you. So these are all the ways and measures how you are going to give a solution for the problem that you jointly identify from between the client and you. And the second visit, you are just going to revisit those and see the improvement. And this tool is a very good tool, which will actually help you finally to assess the adherence of the patient. I'm also bringing in one of the case that from JJ Hospital. Madam has presented, I think, in the last month in the NDLS. So what they have identified is almost around 30 patients. They were on third line therapy, and they had shared all the results for a genotype. That means they did a drug resistance testing among them. To their surprise, what they have found is none of the patients were resistant to even NRTIs, PIs, or even INSTI. That means it is just non-adherence to the drugs that the viral load is increasing, and not really the failure of the drugs. So this is a good data even for us. So don't just think that high viral load means the patient is not doing well. There is a lot and lot more scope for us to work on the adherence of the patient, and these all becomes an unnecessary switch if we keep on switching. So let us look into the patients who have high viral load, drill down into the factors, and we find solutions for them, offer them solutions, and preserve the drugs, second or third line drug, judiciously, so that we don't keep unnecessarily switching patients. And this is a cascade how you monitor this, we have already seen. And when you say EAC initiated, completed, from now on your evidence should be your EAC worksheets, not the date of diagnosis, not the date of HIV testing, adding 3 months to that and saying every patient completed EAC. No, you should have an objective assessment, at least based on the reporting from the tool that we have in the operational guideline. And more so, you see, there are so many tools that NACO had provided, uh, mm, either in the technical guideline or in the operational guideline. You see every session how to do, what to do, how to plan the next session. And for this, every center should follow a differentiated approach and make these patients as your category C patients and have a focused intervention. Intervention is nothing but giving them this step up counseling, understanding their challenges and advising them, or communicating along with them on how best to prevent non adherence. Now, finally, U is equal to U, that is undetectable is untransmittable. This again, you can use this as a motivation for the patient, telling him that if you actually are adherent and have your viral load suppressed, your sexual activity within the family members, or you cannot transmit your infection to anybody in the community. And number two, you can stay healthy and fit with no other virological problems in you. So this is again a strong message for the patients that if you are unsuppressed, you have a normal sexual life and you cannot transmit infection. That itself is a boost, and then to boost the adherence of the patient. So with this, we conclude the session, and you can take the post test.
Thank you, sir. Kiran sir, can we have the post test? All the participants are requested to please attempt the post test. There are 3 questions involved. Please scroll through the questions and answer all of them. These are the same questions that were there in the pre-test. I'll read out the questions. First question. Success of antiretroviral therapy depends on, there are 4 options: adherence to ART, type of ART regimen, age of the patient, all of the. Second question. PLHIV is initiated on ART and at the end of the 6th month, he missed a few doses of ART. Which of the following is the best scenario to manage this patient? The options are: counsel the patient and refer for viral load test, delay the viral load test until the PLHIV attains the desired adherence, counsel the patient, refer for viral load test, and utilize the viral load test result to further motivate for adherence. The third question is: PLHIV initiated on ART in 2020 and is now due for annual viral load test. The counselor and medical officer referred the PLHIV for viral load and the viral load result was 20,000 copies. ART staff initiated EAC and in the 3rd month of adherence was not adequate, that is, it was less than 95%. What is the best option for management? Options are: counsel the patient and refer for viral load test, Continue EAC for additional 3 months and then refer for viral load test if adherent and refer to SASL. Requesting all the participants to please attempt the post-test. You just have to click on the right answer, whichever you feel. Please scroll through all the 3 questions and answer them. Kiran sir, we can end the e-poll now.
Yeah, I think most of them got that second one somehow wrong. So the second question is mainly the first viral load that we are talking about, 6 months viral load. That's why I told a patient initiated on ART and at the end of 6th month, he missed few doses. For that patient, what you do is you have to get a viral load. Continue to counsel. That's what I told. Counsel the patient and use that viral load. Even if your gut feeling says that the patient is not adherent, get the viral load. And really, if the patient is unsuppressed, you use that as a tool to improve his adherence. And you repeat it after 3 months. So the first viral load count, you don't try to keep postponing that one. But if the patient has already got and now you have done a viral load to the patient, um, you're talking about the viral load where the patient has failed. For that, then you take time. If you're taking 3 months, if you think that you can extend it to 4 months, you do it, but don't delay it more than anything. Okay, so the only place where you can at least delay for another 2 or 3 months is after having a viral load count more than 1,000. But before that, the first viral load, please do it timely at 6th month, trying to continue the patient, counsel the patient. Okay. Any doubts? Yeah.
So can we continue the slide?
Yeah, sure.
Here are
Yeah.
the answers to the post-test. Success of antiviral therapy depends on adherence to ART. Second, PLHIV initiated on ART and at the end of 6th month, he missed few doses of ART. Which of the following is the best scenario to manage this patient? This is a patient newly initiated on ART. Counsel the patient, refer for viral load test and utilize the viral load result to further motivate for adherence. Third question. PLHIV initiated on ART in 2020 and is now due for annual viral load test. The counselor and medical officer referred the patient for viral load and the viral load result was 20,000 copies. ART staff initiated EAC and in the 3rd month the adherence was not adequate, that is it was less than 95%. What is the best option for management? Continue EAC for another additional 3 months and then refer for viral load if adherent. Thank you so much, sir, for facilitating this important session.
Yeah. Thank you all. Yeah.
Okay, there's one question, sir, from
Okay.
Usha. A few doses missed means how many?
The question, huh? Okay. So missed more than 3 pills of TLD. Yeah, I should be specifics. Yeah.
Any questions from the participants, please feel free to unmute, or you can even type in the chat box.
Excuse me, sir.
Yeah.
Yes, sir. So that the guidelines says that adherence should be more than 95% for viral load testing in the last 3
Yes,
months.
ma'am.
So if
Last
patient has
3
missed
months.
some 3 or 4 days, and then also we can do viral load testing
Yeah, see,
at the end of 6 months.
yeah, so for the first viral load test that you have, no, it is better to do it timely viral load. Yes, we understand that you may be getting a higher viral load, but you do not want to delay it. How long will you delay that? At least the patient has to know where he or she is. So that is the prime reason. And number two is still you have an opportunity to correct it, no, in the next 3 months.
Yes, sir.
Yeah,
Then
that's the
if he
reason.
has missed more doses, like for 10 days or like, then we have to give 3 months, like after 3 months, no, sir, after his adherence is
See,
corrected.
yes, madam, it depends on why that non-adherence is. If you think that, like, initially I asked some of you told that the patient has gone to some function or
Work.
something. Yeah, work. So those are the things which you can retrace. So maybe delay for a month and then just get it, because these are all known factors, right? And
Okay, thank you.
we are using dolutegravir. So I mean, don't tell this to the patients, but as you know, technically, this is a bit adherence forgiving drug. So it will weigh in towards getting the viral load test done for a patient. Okay.
Okay. Thank you, sir.
Yeah.
So, sir, thank you so much for the session. Wonderful session. I have a question, sir.
Yep.
So there'll be a PLHIV. His or her viral load will be done in the 2020 or
Okay.
2021. Then she or he will be her viral load will be more than 1,000.
Mm.
And she.
Okay. Yeah, continue, ma. I just heard that the patient's viral load is done in 2020 and viral load is more than 1,000. Yeah, continue after that.
Ma'am, can you please unmute? So I'll take the questions from the chat box till then.
Yeah.
For the patient is on AKT and viral load is due, so we do or not? If a patient is on
Yeah.
AKT.
Yeah. So if a patient is diagnosed to have tuberculosis, there is a relative raise in the viral load at that point of time. So you just at least finish the intensive phase and get the thing done. Okay. So there is some literature which shows that, which indicates that there is a raise in the CD4, in the viral load count when you have an active opportunistic infection. So possibly at least wait for that 1 month, 2 months of the intensive phase if you're talking specifically of AKT, and then possibly we can get the viral load done. So these are all, again, as I told you, very good questions. I cannot say in blanket to every patient do it, but these are all the exceptions. Very good, you are asking questions, but don't apply the same thing to every patient. So to your question, yes, just wait at least the intensive phase so that there is a rapid infection of tuberculosis that is reduced, and possibly there may be a relative decrease in the viral load if it is due to that infection, and you may be getting the real viral load of that patient. Yeah.
So there's one question: how to manage patients who are LFUs and have higher viral load?
Yeah. So now if a patient is coming after an LFE, immediately don't do a viral load count, because that's not going to help. There's definitely going to show that he or she missed the pills. That's why the viral load count will come so high. There's nothing as a medical professional you have diagnosed something new. But what you can do is, if there was so much, if the patient had his viral load maybe a couple of years back and now he's due, now he's LFU, at least put him on treatment, continue the same treatment. What are the patient, if they were on TLD, continue TLD for 3 months, and possibly in these patients you can get a viral load done after 3 months. It is just to see whether the drug is working. That's what you want to know. So you know that TLD in dolutegravir has a rapid viral suppression. So maybe in 12 weeks, it has a rapid viral suppression. So you can at least do in third or fourth month after that when a patient is coming to you. Because if you do immediately, it's going to be higher. It doesn't have the clinical value.
Participants? So I don't think there are any questions. Thank you so much. Okay, there's one big one. So just give me 2 minutes. Yeah?
Yeah, when we know that the patient behavior after many seating for adherence, but patient accept all the time to improve adherence, but not taking medicine every time with no reason, till what time we have to. Yeah, this is what I'm saying. You get it done at one point of time when the patient is vexed and you are vexed. It's like you get it. You have done first 3 spells, next 3 spells, and use that viral load to show him the score. Tell him that, Are Baba, you have done so much of 6 months, but see, you are not taking your drugs. That is reflecting on your viral load. So at least use that count. There will be some patients in the 5% of the patients that we have greater than 1,000, at least 1% of them will be this group. So please judiciously use the viral load, but the purpose of using that count for that unsuppressed patient is to just to show him something objective. Always you are only counting pills or asking him, but now you have an objective assessment that is having a viral load. Show him if he's getting in lakhs, tell him you need to take for 3 months and at least see that it comes to thousands or an unsuppressed viral load. That is how you fix a target to a patient based on that count that you have. Yeah. But I have no direct answer for you. Do it in 3rd month, 4th month. It is that patient whom you are dealing with. And I have given you all the evidences. I have told you all the possible ways how you can get the viral load test done and why you are using that test now. Yeah, thanks.
So much, sir. Thank you to all the participants for patient listening and participating in today's session. So can we conclude the session now?
Yes. Thank you.
Thank you so
Thank you,
much.
Shweta.